and a child and run paradigms where we're collecting data on their brain activity at the same time. And so we look at that data, and to assess synchrony, it gets fairly complex mathematically, but just at a very baseline level, we're comparing two sets of brain waves and looking at the correspondence between the two. So we're interested generally at what points the brain activity in the parent mirrors that of the child. And it gets pretty cool and interesting because we're able to kind of shift that baseline sometimes to see whether or not things are parent driven or child driven. So really leads to some interesting research questions. And so we were fortunate enough recently, so we're pretty much finished with data collection on this project now, which is exciting. Takes a long time to do. And we recently just had an abstract submitted for a special issue in Developmental Cognitive Neuroscience, which is a great journal in our field. And so we're preparing a paper to submit early in the spring. And so just a teaser with our results here. I just have one slide. Our overall findings, and I just talked about brain synchrony thus far, but we collect a lot of different data. So while children and parents are having these EEG headsets on and doing particular tasks, in this task, we have them doing a visuospatial game, which you might recognize as Jenga. But we have different conditions. So we're looking at when parents and children are cooperating, but also when they're competing. So your typical Jenga game, you pull a block, I pull a block, who knocks it down, they lose. But we also kind of modeled this cooperative situation where we tell the dyads that it's the aim of their game is to work together to build a tower. And so in that instance, they're coaching each other, helping each other out, saying, you play this block, you play that block, things of that nature. We videotape these sessions. So we have live video on the entire interaction, and then we code that behaviorally for the extent of parent-child engagement during the session. We also collect saliva, so we assess that for oxytocin receptor methylation, which has been shown to correspond with parent-child engagement and attunement as young as infancy. So we're really excited to have this interdisciplinary approach here. And so what we're finding so far is that indeed there is correspondence between methylation of parental oxytocin receptors with the neural synchrony during this competitive gameplay. And you can see just a graph here showing some of the results where the mean EEG synchrony is correlated with oxytocin receptor methylation. And it's a negative slope because it's actually kind of counterintuitive, but there's the more engagement, the less methylation there is. So just think of it, it opens up the receptor and allows for more oxytocin to come in. And so I'm just going to shift gears for a minute, and this is tough in a 5-minute talk to shift, but I also have another arm of my research that falls more under math learning in children. So I successfully applied for and received an R01. This was just at the end of my iTHRIV training. And also recently got a renewal for my loan repayment program application, which is incredible because now all of my undergraduate student loans after this award comes up will be paid off, which is a bonus. And so this is my first R1, my first major research project, which is incredibly exciting, just making that transition from fellow and scholar to independent researcher. And the main overarching idea with this work is to look at the extent to which memory brain systems support math learning outcomes. And so we look at two different memory systems. We look at declarative memory systems, which support retrieval or fact learning. And we look at procedural memory systems, which support more, intense strategy, procedural-based type of learning. And we look at a brain level. So in this study, we're actually collecting longitudinal structural and functional MRI data, where we're examining and characterizing these brain systems in memory and math in children from 7 to 10 years old. And I'll just flip to the next slide, which gives you a better idea of the population. So again, yes, declarative and procedural memory in relation to mathematical operations. We start with 7 and 9-year-olds, and then we see them again 1 year later when they're 8 and 10. And this is kind of a like workaround cheat. So the best way to do developmental research is to have a true longitudinal study where you see children, the same children year after year after year. But that gets really tricky when an R01 is 5 years long. So we do a little cheat where it's 2 different groups, but we're still able to track a developmental trajectory, which is more accurate and better than a cross-sectional study where we're able to look at some individual differences. And so we'll initially look at some cross-sectional data and then eventually do longitudinal modeling of the profile from age 7 to age 10. Very excitedly, we're up and running with this project and, in full steam with data collection. The timing was uncanny. So I received this R01 funding in the summer of 2020. Everyone knows what was going on in the summer of 2020. So there's been a little bit of a hiccup here. So we've had to stall with data collection, but we had a lot of time to think about this and really design a study that we were super excited to implement. We'll probably apply for and no doubt receive a no-cost extension because they're extending most grants these days because of COVID-related changes. But it's just really exciting work for me and looking forward to, continuing on and progressing in these multiple domains of research. So just a quick acknowledgement slide, funding through the KL2 iTHRIV program, the R01 that I received, the STAR internal funding at UVA, and the LRP. I had co-mentors on my iTHRIV fellowship, Kevin Pelfrey and Stephen Boker, which both have been instrumental with this work. I have collaborators, so Jessica Connolly is the epigeneticist who helps with the methylation work, and Ian Lyons is my co-PI on the R01. I have a lab manager who does everything and students that have been incredibly amazing. So the first student listed here, Leela Shah, was my de facto lab manager when I arrived at UVA. It was just me and her in our lab. Mentoring my first graduate student now, which is really exciting as well. And just, have had really, really great interest in the lab from tons of undergrads. So our biggest barrier now is finding enough work for them to do, which I think is a good problem. So with that, I'll end and happy to answer any questions you might have.
Thank you, Tanya. We're actually going to move on to Katie's first, and then we'll have some time for Q&A after her presentation. But thank you very much.
Yeah.
All right, now I'm having technical issues with unmuting. Can everyone hear me okay?
Yeah.
Okay, great. Hello, my name is Katie Love. I am an assistant professor of medicine. I'm an endocrinologist at UVA and delighted to talk a little bit about my research. This is sort of a 10,000-foot view like Tanya's, that I'll talk a little bit about the ground I've covered as an iTHRIV scholar and then what some next steps are for me briefly. My disclosure slide. So my research focuses on vascular health in type 1 diabetes. Type 1 diabetes is an autoimmune condition where people don't make enough insulin, and this predisposes people to issues with both high blood sugars and low blood sugars, both of which are detrimental for vascular health. Now, type 1 diabetes is particularly difficult to manage with most people with type 1 diabetes not achieving target glucose control. And even of the people who do reach those thresholds, there's still a greatly increased risk of cardiovascular death compared to the general population. And this risk only increases with declining glucose control. So in my opinion, adjuvant treatments would greatly improve this medical condition. Now, as I said, my research focuses on vascular health and specifically the endothelial cell level. And endothelial cells line the inside of the blood vessels, and inside the endothelial cell is an enzyme called eNOS, or endothelial nitric oxide synthase, which responds to stimuli like insulin or shear stress to produce nitric oxide, and nitric oxide dilates the blood vessel. And that's important for health because dilation of the blood vessel allows the delivery of glucose, insulin, other nutrients to the target tissue. And I particularly focus on the microvascular level, which directly perfuses the muscle, which is a major target for insulin. Now, we do two major techniques to look at endothelial function. One is flow-mediated dilation, and this is where we inflate a blood pressure cuff and release it, and that increase in blood flow, like if you've ever had a blood pressure checked in the doctor's office, that increase in blood flow when the cup is released causes this shear stress, and that should trigger that nitric oxide production. We particularly focus at the microvascular level, and the way we look at that is by a technique called contrast enhanced ultrasound, where we infuse these micro bubbles and look with ultrasound before and after an insulin clamp to see changes in microvascular function. And in other insulin resistant conditions like type 2 diabetes and obesity, sometimes when we give insulin, we actually see a contraction of the microvasculature. And I'll show you data that this is also happening in type 1 diabetes as well. Now, using that contrast enhanced ultrasound technique that I just described, we have seen in a large cohort, including some of whom have type 1 diabetes, that impaired microvascular perfusion with this technique, as I said, is independently associated with whole body insulin resistance when we control for a number of factors like BMI and VO2 max. And others have shown in the type 1 diabetes population that insulin resistance is a predictor of cardiovascular disease. Now, whether this impaired microvascular perfusion, directly, is associated with cardiovascular disease is yet to be defined, but an important area for future research. Now, I said that there's early data that there's insulin resistance in type 1 diabetes, and this was looking at adolescents with type 1 diabetes who are just 14 years of age, and already there's evidence of endothelial dysfunction compared to their peers. And at the microvascular level here, again, we see essentially a reduction in microvascular blood flow with insulin. This was data from others, but has been a major interest of mine that using GLP-1 or glucagon-like peptide 1, there's an improvement in larger vessel endothelial function and an improvement in oxidative stress in people who have type 1 diabetes under conditions of both low and high blood glucose. And so this has led to my next steps in research, which should be under a K23. I was able to submit and resubmit a K23 application during my iTHRIV time. The resubmission has a promising score and should be funded. So I'm about to start there, where we're looking at a GLP-1 receptor agonist and exercise training over 14 weeks in people with type 1 diabetes. And we're doing a number of other interesting things like looking at continuous glucose monitoring and looking for correlations with microvascular function, and also looking at a new biopsy technique learned through University of Colorado as far as biopsying the endothelial cells and looking at proteins of interest for endothelial function, and also looking at oxidative stress. So the upcoming 5 years, and I'm not going to go through this, but enough to say that the iTHRIV Career Development Award has allowed me to really get a wonderful foundation for future research as an early investigator, and certainly as someone who had mostly had a clinical background. So I am so appreciative to iTHRIV and my mentorship team, especially my mentors, and iTHRIV, particularly for all of the support through the years. So thank you. And I have to also apologize that I have to leave a little bit early today because I am attending on consults right now. So I'll have to leave shortly.
Thank you, Katie. We can take a couple moments for Q&A for the alums that have just presented for us, and then we'll move on to our next group, which would be our second years. Anybody have any questions for Tanya or Katie?
Can I ask you a question, Tanya?
Yeah, of course.
Now, as an endocrinologist, I'm going to, ask about hormone. So I was wondering, you had mentioned that you use plasma for your oxytocin receptors, or I'm sorry, you use saliva.
Saliva, yeah.
And I was wondering, and that's so great for a young population because obviously they're not going to want blood draw. Have you found a good correlation with plasma levels, and how quickly do you see changes in salivary levels?
Yeah, so from what I understand, and again, this is Jessica Connolly's area of research, which I'm a collaborative investigator with. From what I understand, they do see pretty strong correspondence with the plasma and saliva data. But as you mentioned, I think if you're really interested in characterizing the response temporally, like if you want a profile that is connected with a very specific aspect of a protocol, then plasma is the way to go. But on a, at an aggregate level, saliva is pretty comprehensive and accurate and has been shown to, again, relate with this.
What is the real story of January 6th? Many people have asked that question.
I had a question for Tanya.
Yeah.
So I was wondering about the methylation that you mentioned. So is that something that reflects kind of the overall quality of the parent-child relationship, or is that something that changes based on, like, in the moment based on the connection during that particular activity that you would have them do?
So both.
Okay.
So kind of just related to Katie's question, if you want moment to moment, you'd look at plasma, but the methylation has been shown to vary across time, but just holistically at a whole level, there's strong correspondence with this methylation and parent-child engagement, attunement relationship. There's some really interesting work from Jessica's lab, and I think the lead investigator is Katie Kroll. It was written up in UVA Today a couple months ago, and they were showing just that they could, predict, not only show the correspondence at the same time, but predict the relationship quality overall years later based on the methylation data at infancy. Thanks for the questions.
Okay, we're going to go ahead and move on to our second years with Greg Madden. Again, Katie and Tanya, thank you very much.
Hi, everyone. My name is Greg Madden. I'm one of the second year scholars and assistant professor in the Division of Infectious Diseases here at UVA. And today I'm talking about Clostridioides difficile, or C. diff, infection. And to start off, up to a third of patients hospitalized with C. diff infection will end up requiring intensive care, and over 6% will end up dying of their infection. And so we need better treatments. And a fundamental barrier to discovering better treatments for this infection is that we don't have a reliable and individualized risk model to tell us at the time of diagnosis who those high-risk patients are. The current consensus guidelines rely on just 2 lab measurements to stratify severity, which is a demonstrably poor predictor of those outcomes. And there are good reasons why I think conventional models don't work well, which is that they reflect an outdated and really overly simplistic paradigm of C. diff pathogenesis, which I kind of mocked up, shown here. And what we now know, based on the past 2 decades of research, is that key aspects of a patient's immune response are really what drive severity in this infection. And the host immune profile, so to speak, looks more like this picture on the right. For example, it turns out that the neutrophil response that is closely associated with pseudomembranes and other complications of C. diff infection early on are controlled by something called Th17 cells, which are a subset of pro-inflammatory helper T cells. And then the Th17 cells themselves proliferate in response to something called interleukin 6 or IL-6. So we know patients with the highest levels of IL-6 at the time of diagnosis are 7.5 times more likely to die with their infection. And there's limited evidence, including work at UVA by myself and others shown on the right here, that measuring these important cytokines in the blood without knowing much else about a patient perform even better than the clinical only models that are available for predicting outcomes. And this brings me to the second phase of my iTHRIV project, which is to use a large clinical database for C. diff. I now have over 100 putative clinical factors combined with this immune biomarker profile, as well as pathogen virulence factors to create what I call an integrated clinical immunologic model that we can then validate prospectively. And the most immediate impact I think I'm most excited about of this work will be an experimental early risk stratification strategy that we could implement to enroll patients really much more efficiently in clinical trials, and which has been a barrier in this field. Thank you.
Thank you, Greg. We have about a minute that we can take for Q&A for Greg, if anybody has any questions.
I can ask one for Greg. The biomarkers you described are super interesting, but it seems like few of them are measured in routine clinical use. Do you have a signature there that might be more like immediately identifiable?
Yeah, what I imagine is something like the reveal score for like pulmonary hypertension, where there's a sort of a more invasive or data-rich profile, like the full reveal score. I think it's called the reveal score for pulmonary hypertension. And then there's like a reveal light where you just have the clinical parameters. And so that would kind of be the practical way to implement this. But the 17-plex ELISA assay that we use to measure the cytokines is something that is totally feasible to implement in the future if this is, validates well at multiple centers and so forth. That could be feasibly used to guide clinical practice.
Cool, thanks.
All right, thank you, Greg. And we're going to move on to Shauna. And if we have time, we hopefully can take a couple more questions for second years at the end of Shauna's presentation.
There we go. There we go. All right. So, my name is Shauna Klain. I am a veterinarian, board certified in. Can you hear me?
Yes, but we see your presenter view.
Got it. Okay. Let me try that again. Not sure how to switch that. I think there's a little button. Here we go. How's that? Better?
Yes, perfect.
Yeah. All right. Great. Sorry about that. So my name is Shauna Klain. I am a veterinary oncologist at Virginia Tech. Go back to this. Sorry. So half of patients with soft tissue sarcomas will develop metastasis, and the 5-year survival rate once metastasis is detected is 16%. And that's because the systemic therapies, chemotherapy for soft tissue sarcomas are largely ineffective. And although immunotherapies have been advanced in other cancers, they're really slow to develop in soft tissue sarcomas. And that's because there's a lack of robust immune biomarkers to help us identify what the immune tumor status is. So clinical trials in pets with cancer have a high translatability, and that's because their tumors develop naturally within the context of a complex tumor immune interaction, and most of the cancers are clinically similar, genetically similar, and we have the same diagnostics and treatments. And so we do clinical trials in pets with soft tissue sarcomas, and we use a technique called histotripsy, which literally translates to crush tissue. The tissue is actually crushed by the expanse and the collapse of gas pockets within the tissue, and that's due to the negative pressure from the focused ultrasound pulses. And we can see this bubble cloud in real time during our treatment, so we can actually visualize where the tumor is being destroyed. And this subcellular ablated tissue has been shown in rodent models to generate an anti-tumor immunity and enhance the efficacy of immune checkpoint blockade. And recently, in the last month, there was the first clinical trial in humans with advanced liver tumors, this first-in-man histotripsy study. And 2 of the patients in this study did demonstrate the abscopal effect, where you treat one tumor and tumors that were not treated actually receded on follow-up, which is really interesting. So histotripsy may be an immunomodulatory therapy. So we recently demonstrated safety and feasibility of histotripsy in pet dogs with soft tissue sarcomas, and the ablated area is sharply demarcated on cross-sectional imaging, on gross histology, as well as on histopathology here. Evaluation of the tumor microenvironments 4 to 6 days after histotripsy revealed an infiltration of macrophages here at the treatment interface. And there were 79 genes that were upregulated with the immune response, specifically with inflammation, immune cell migration, and wound healing. Now, these findings may be just a reflection of the time frame that we evaluated, which aligns with the normal wound healing response, or it could be that our partial ablation was insufficient to stimulate a robust anti-tumor immune response. Or it's possible that histotripsy liberated extracellular vesicles that are trapped in the extracellular matrix. These are called matrix-bound vesicles. So a little bit about extracellular vesicles. These are small particles that are released from cells, and they carry protein and genomic cargo. And EVs that are generated by cancer cells can induce angiogenesis, make nearby cancer cells more aggressive. They can suppress the immune response and also prepare distant organs for metastasis. However, clinically, we can leverage EVs to discover new biomarkers and facilitate a liquid biopsy of cancers. But how and if histotripsy impacts EVs is unknown. So other forms of focused ultrasound, specifically low-intensity focused ultrasound, has been shown in vitro and in patients with brain tumors to facilitate a liquid biopsy of EVs, but also downregulate cargo associated with tumor progression. So this is the basis. This work was started before my iTHRIV Scholar program, finished during my program, and now is the basis for an R21 that we put in yesterday, in which we will prospectively enroll dogs with soft tissue sarcoma. They'll be randomized to either a high or a low total tumor ablation, and we'll collect serial blood samples from 30 minutes up to 10 days after treatment. We'll get blood and plasma samples. These will be sent to a collaborator at UVA, where they'll use flow cytometry to profile the immune cell populations, as well as isolate the extracellular vesicles and characterize them by size, concentration, and flow markers specific for EVs. And then they'll ship the EVs back to me, where I will look at 800 genes associated with the immune response. So looking at cargo in the EVs. So just want to acknowledge there's a wide variety of people involved, everywhere from veterinary specialists to human radiologists, as well as my engineering collaborators, specifically Dr. Eli and Dr. Shaibani at UVA. Thank you.
Thank you, Shauna. Does anyone have any questions for Shauna?
Hi, Shauna. Nice presentation. You talked about, the high volume treatment needing to treat more than or ablate more than 50% of the tumor. Is that kind of the solitary tumor? Are there patients that are going to have metastatic disease, and kind of do you expect that to play a role in your results?
Yeah, thank you. Thank you for asking that. So the treatment would be to the primary tumor, and it actually would need to be delivered over 3 different sessions. And that's because of a limitation with our technology. In order to do, well, we don't have capacity to do rapid volumetric ablation of tumors. And in humans that are undergoing ablation techniques, when you do a high percentage ablation, they can have something called post-ablation syndrome within the first 24 to 48 hours, where they actually feel ill. And so we're doing 3 separate treatments of smaller percentages, and they're about 3 to 4 days apart, so we can monitor the patients in between. Metastatic disease is not an exclusion criteria, so we will accept patients with metastatic disease. And personally, it would be very interesting to me to monitor those patients through time to see if we can demonstrate, potentially an abscopal effect.
All right, thank you so much, Shauna. In the interest of time, we are going to now move on to our first year presenters. And so we're going to start with Shannon Armbruster. So Shannon, whenever you're ready, we can go ahead and share your screen and start.
Okay, there we go. So thank you for letting me present my work in 60 seconds. My research focuses on endometrial cancer survivors, which is the most common type of gynecologic cancer that women undergo. It's directly related to sedentary lifestyle and also obesity. We cure most of these women of their cancer, but after they're treated and in the survivorship period, they have quality of life issues as well as comorbidities that are above those of women with the same BMI without cancer. There's a lot of focus, as we all know, being in the month of October, on breast cancer survivors, but uterine cancers make up the second largest group of cancer survivors. And so it's kind of my passion to try to help address these issues for this group of women. So our project involves taking FitX, which is a walking physical activity and fruits and vegetables based intervention that's been used for prevention of obesity related issues in the general public, and adapt it for endometrial cancer survivors. So we have a 3-arm randomized trial that will have a control group as well as FitX with a walking focus, as well as that of a yoga focus. The cancer survivors that are within the intervention groups will recruit up to 5 individuals to go through the intervention with them. And our thought is that if we're improving the choices of the people around the endometrial cancer survivors, we're making environmental changes that will hopefully help the sustainability of these changes for our survivors and also for their immediate family and friends. So our primary outcome will be moderate to vigorous physical activity, and then we'll look at our secondary outcomes of quality of life, flourishing, and those type of outcomes that might be different when you're taking a more mindfulness approach versus a purely exercise approach. Okay, that's it. Thank you.
Thank you, Shannon. And I think we have time for one question if anyone has any for Shannon. Then we'll move on to Rao, who's our next presenter. All right, Ralph, if you want to go ahead and pull up, we'll also have some time at the end for some Q&A for our first years as well. We tried to incorporate that in our schedule for each group this year.
Hi, everyone. I'm a veterinarian neurologist at the Virginia Maryland College of Veterinary Medicine. And basically, studies have shown that the alpha-6 nicotinic acetylcholine receptor is downregulated in chronic pain, and specifically during the development of allodynia. And allodynia occurs when a stimulus that is not normally perceived as painful causes pain. This can develop after several types of injuries, with the two primary examples being inflammatory or neuropathic injury. And the underlying mechanism causing allodynia may be different between these two types of injuries. Our thought is that by better understanding the changes that occur in the alpha-6 nicotinic receptors, we may be able to develop better drugs to treat chronic pain in animals and people. We will use mouse models containing fluorescently tagged nicotinic receptors, and following induction of allodynia in these mice, we'll use whole cell patch clamp to measure currents mediated by these receptors in the dorsal root ganglion and the dorsal horn of the spinal cord. We hypothesize that the downregulation of the nicotinic receptors following injury will result in decreased currents that are nicotine mediated in the dorsal root ganglion and alters the synaptic input to the dorsal horn of the spinal cord. Thus far, we're optimizing our models of allodynia and our electrophysiologic methods. And I'd like to say thank you to my mentors, my lab help, and thank you to iTHRIV for the opportunity to work on this research.
Thank you, Ral. We have a little bit of time for questions. If anybody has any questions specifically to Ral.
Well, I'm curious how you measure allodynia in the mice. How do you know that they're actually experiencing that?
We do a behavioral test called von Frey testing, which basically we test their sensitivity to filaments of various size. And we measure over time whether they become sensitized to the sensation of touch, basically. And so that's a common method of measuring allodynia. Thank you.
Thank you, Ral. Iren, we are ready for your presentation next.
Okay. So thank you all. My name is Iren Mattia, and I'm an assistant professor of pediatrics in general pediatrics. So I'm going to talk about my project to approach the adolescent mental health crisis through community engaged methods. We know that prior to the pandemic, pediatric mental and behavioral health was worsening, and the past 2.5 years have only increased that phenomenon exponentially. But we also know that this was not evenly distributed, and that youth of color and or LGBTQ youth have been most impacted by the mental health effects of the pandemic and related political and social events of the past couple of years. We also know that we have not nearly enough resources in our community to address the current needs and disparate access to the existing resources. And while there are many interventions, including clinical as well as non-clinical interventions to support youth mental and behavioral health, we need more evidence for some of these interventions. And also we need to assess community nuances, needs, and priorities to determine the most appropriate interventions for given communities. So my project is to use a mixed methods approach to better understand this crisis in context of Central Virginia. We're going to use electronic health record data to quantify the disease burden in terms of common mental and behavioral health disorders in our patient population of our primary care clinic in downtown Charlottesville. And we also want to learn more about community priorities, strengths, and wishes with respect to improving adolescent mental and behavioral health. We'll do this through an approach called Youth Participatory Action Research, which is a participatory approach in which youth are actually co-researchers rather than simply participants who help to create the qualitative instruments that we will use to measure these impacts and the nuances that aren't reflected in the quantitative data. And finally, I'll be helping to measure the effects of the Compassionate Schools Project, which is an innovative socio-emotional learning curriculum that's currently being implemented in Charlottesville City schools to see what impacts it has on mental health down the line. I want to thank my collaborators, which include a wide variety of interdisciplinary scholars from the Education School, as well as Contemplative Sciences Center and my Department of Pediatrics. Thank you.
Thank you, Iren. We have a moment for questions for Iren, and then we'll move on to Andrew for his presentation. All right, Andrew, we'll go ahead and have your presentation, and then we'll have a little bit of time at the end for some Q&A for all of the first-year scholars.
Sorry, I lost my mute button there. So I'm in the Division of Pulmonary and Critical Care here at the University of Virginia, the Department of Medicine. This is my iTHRIV project, which is titled Machine Learning to Improve Sepsis Care. So sepsis is a life-threatening infectious condition that is present in about 6% of all adult admissions and has a surprisingly high mortality. It's a time-sensitive condition with delays in treatment being associated with an increased risk of death. Despite all this sort of prevalence and negative consequences, just over the last 30 years, there's basically no sepsis-specific approved therapies, and a lot of effort has been placed on identification of sepsis. My project is sort of sidestepping to later down that pathway. So after sepsis has been identified, can we use machine learning to sort of develop next generation clinical decision support to help facilitate rapid treatment delivery? And so I'm building a model that's going to take in sort of labs, clinical observations, and vital signs, combine them together to predict people who are highly likely to develop septic shock, and then use that to trigger a downstream alert for a pharmacist to help facilitate a sepsis response team sort of in an automated fashion rather than requiring manual identification. And with that, I'm happy to take any questions.
Amy, can I ask a question?
Yeah.
Andrew, when I think about like machine learning to like your project, you know, to be able to diagnose earlier, better, or whatever, I often think about the doctor side of that equation, and can you convince the physician that this is a useful tool? But I'm wondering, is there any thought around on the patient side of that? Like, will it be hard to convince a patient, look, we need to intervene this way because the computer model tells me to? Is there ever any thought from the patient side of that equation?
Yeah, so two things. So one, for my project specifically, I'm trying to identify at the time of physician diagnosed sepsis who's going to be high risk, so that we can essentially pull a fire alarm in that scenario and bring extra resources that we wouldn't do all of the time. So I am sort of trying to nightly sidestep that whole diagnostic question, because it's really just identifying when somebody has diagnosed sepsis. The patient perspective is one that is like very intriguing to me. It's not sort of in this specific project, but I actually have a different collaboration with a neonatal intensive ICU and 2 centers where we're going to try and look at patient perceptions of these, because these models are out there, they're on the walls of the hospital, and yet I don't think anyone's ever really asked patients and patients' families how they feel about these risk scores and changes in those components.
Yeah.
And that's with Bryn Sullivan, a former iTHRIV scholar. And there she is.
Andrew, this is Leonie. Have you looked at, the epic sepsis model and the issues that it had? How is your predictive model going to be different? And I understand there may be a difference to the.
Yeah. So the epic sepsis model, which was didn't perform as well as they had hoped, was specifically trying for early identification. And I'm focusing on the downstream effects. So it's basically at the time of when somebody prescribes antibiotics, can we predict who's likely to develop shock and then trigger a special alert for them? So just trying to balance this alert fatigue. We don't want to send an alert out every time somebody prescribes antibiotics, but to identify a subpopulation that is at highest risk and might derive the most benefit from a pharmacist coming to the bedside and helping facilitate administration.
So and I'm sorry, I'm short on time, so we can always take this offline. We have plenty of time to talk about this. But so it's still a clinician-based activity, though, right? It's not the patient-based activity.
I don't know that I understand. Sorry.
So your notification is going to the clinician and not the patient. That is correct, right?
Yeah. To a pharmacist.
Yeah. Yeah, we can talk offline on all of these projects. Thanks.
Yeah. I think one of the advantages of that point is that since someone is already diagnosed with sepsis, you're free to use sort of all sorts of features and predictors that wouldn't otherwise be reasonable. Like you can use a blood lactate level, which is a marker for clinical sepsis. And so it's probably not correct to use that to trying to predict it early, because once it's been checked, somebody already suspects it. But in this model, it's well established as a biomarker for stratifying risk.
Amy, can we ask questions of any of the first year scholars? Is that what this is right now?
Yes, correct. We have about till 2:55, then we gotta go back to the main room.
So, Irene, I'd like to ask a question of you. So, the mental health challenges associated with COVID and particular vulnerable populations that you talk about. I'm wondering what kind of extension is there to, like, how much of those challenges are going to be unique to COVID, and some of the lack of resources and challenges came from that? How much, 10 years from now, is that going to be relevant to situations? I'm framing the question poorly, but I guess I'm just trying to figure out the generalizability of some of the mental health challenges from this particular point in time.
Sure. Well, I think that COVID really shone a spotlight on a phenomenon that's been an issue long before this. Actually, the first time I met Dr. Notaro in person was when I was a senior resident, and we were both attending a National Academy of Sciences, Engineering, and Medicine meeting about the mental health crisis in kids and how pediatric programs needed to do more to equip general pediatricians to address this. So this has been a long time coming. I think COVID accelerated a lot of the previous issues by creating these social and economic stressors. And it's also shown a spotlight. So I guess the silver lining is that it's shown a spotlight for the rest of the nation who aren't pediatricians and mental health providers on what was already happening, because it got so much worse. I do think that COVID represents kind of an acute moment in time where there was an increase in this pathology. And we're starting to see a little bit of some of the normalization as kids are going back to school and having access to community resources. But I think the point remains that this is a long-standing phenomenon, and there are many, many other factors, which I don't have time to go into now, that I think are around kind of social and political phenomena that were already occurring pre-COVID. So my hope is that we can sort of capitalize on this momentum and this energy that people have for this issue right now to develop new, not just therapeutic, but also preventive paradigms and approaches that can be implemented, knowing that we just don't have enough therapists and psychiatrists to meet the need.
Got it. Thank you.
Well, that's all the time we have for our breakout room. And thank you everybody who presented and who came and attended. If you could please just leave the room instead of leaving the meeting, you'll go to the main room, and that's where we'll have our closing remarks by Leanne. I believe the other room is wrapping up as we all wait. So we'll give them a few more minutes, couple more minutes.